Regular pediatric care is a vital part of not only keeping your child well, but also providing guidance throughout your child's development. From birth to adulthood, pediatric medicine tonight on Call with the Prairie Doc. Hello, I'm Dr. Debra Johnston, tonight's Prairie Doc. Thank you for joining us again as we provide health information based on science, built on trust. Tonight, we're discussing pediatric care. Joining us in the studio here in Brookings are Dr. Daniel Boadwine from Avera Medical Group Family Health Center in Sioux Falls, and Dr. Craig Crismon from Prairie Lakes Brown Clinic, Northridge, and Watertown. Welcome, gentlemen. I'm so happy to have you.
Thank you so much.
Happy to be here.
Dan, tell us a little bit about you and what made you decide to be a pediatrician?
Yeah, so I'm a general pediatrician, do mostly outpatient with some nursery work when babies are born, which is always really, really fun. Mm-hmm. I'm born and raised in South Dakota, went to high school through Washington and Sioux Falls, and then had bounced back and forth between Nebraska and South Dakota for my training and undergraduate. I met my wife in medical school, and we've got a few young kids at home that are almost 7, 5, and then almost 3. And peds was just always my place. I always found myself, gravitating towards, the kids at family gatherings and spending time playing games with them and coming up with new creative ways to be active outside. So that was just always my main area. And I think I knew it longer than I actually knew it when I was in school. So peds was always my place.
Craig, how about you?
Well, I grew up in Florida, but my mom was from South Dakota and went to Sioux Falls College, which is now University of Sioux Falls, and so that's where I did my undergraduate work. And then I went to med school at USD, and then I did my pediatric training at the University of Florida in Gainesville. And then one of my friends from college and med school signed a contract to come to Watertown and said, they don't have a pediatrician, why don't you come up and join me? And so in August, it'll be 31 years that I've been in Watertown.
Yeah, it's kind of getting serious.
It is.
I think that might be where you stay.
It's a strong possibility.
That's fabulous. Before we start our conversation, we invite you, our audience, to submit your questions about pediatric care. We look forward to answering your questions. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We'll work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we don't get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for our newest Prairie Doc publication. The winner will be announced at the end of the program. Your question will remain anonymous, but please provide contact information if you would like to be considered in the drawing. And I'm really excited, guys, because we have some questions that came in ahead of the show. So this is wonderful and some really good questions. So this is one we were actually talking a little bit before the show, Dan. My child would like a trampoline. Are these safe for children?
It's such a good, broad question. I would say from a standpoint of exercise, yes, there's a great component of exercise, and it's great to encourage physical activity. It's hard. This is a question we go back and forth on at our house too. How safe can you be on a trampoline? And there's pros and cons both ways. There are safety nets, and there are things that you can provide some structural safety so that kids don't bounce off the outside. Mm-hmm. But when I was younger and I was a teenager, that meant I could be a little bit more rough because I have a safety net. So I think if it is something that you do endeavor into, it's really just like anything in pediatrics. It's having that conversation with those kids and making sure that they know, all right, these are where the ground rules are. This is where we might ask you to stop if you're being a little bit too rough, and where some of the slippery edges might be if you were to be a little too aggressive playing on it. So I think from that standpoint of answering it generally, it's tough to say overall if it's a safe 100% of the time, But just like everything, if you're going to use it, make sure that you've just discussed that with the kids and gone through it.
Craig, what kind of rules do you suggest to parents if they're going to have a trampoline?
Well, for sure, have a net on the trampoline. As Dan said, that provides some measure of protection, but I'm not a fan of trampolines. I think
me either.
They're quite,
that might be our being old.
they're quite dangerous, and my kids didn't appreciate that growing up. But I think that there's too much risk of harming yourself with the trampoline, and if a little bit is good, a lot is better, and so kids just get more wild, and as long as there's more than one on at the same time, they're going to land on the other person, and I've seen quite a few different types of injuries with trampolines.
Do you have any rules that you suggest for parents if they're going to have a trampoline?
Yeah, so we've talked to our kids just because we have some trampolines in the neighborhood too, and just trying to establish that we don't have eyes 100% of the time. If they're outside, they're playing with our neighbors and they might jump onto it, and so trying to talk to them about being really careful, especially when there's multiple kids on there, not ever intentionally bouncing into others. I know really being careful if it's slippery at all, so if it's been raining, anything like that, you can just take think it's a really stable bounce and you can have your legs go out from under you pretty quickly. And then we've told them too, which kids sometimes don't always listen the best, but we've always told them you have to have somebody watching you while you're playing, just so that we can ensure if it is getting out of hand that we put kind of an end to it.
Good. Here's a question. How do you establish healthy eating habits for toddlers? This child won't eat anything except macaroni. Craig, what is your guidelines for parents there?
Well, for sure you need to keep offering the various foods, because they've shown that a child has to be exposed to a particular food 7 times before they'll even consider it. And so understand that toddlers, by their very nature, their favorite food today is, I don't like that tomorrow, and so you have to kind of go with the flow, but continue to offer a variety of foods. Understand that if you really are worried they're not getting enough nutrition, a once-a-day multivitamin is always a reasonable thing to do. Understand that if you can't go with the concept, if a little is good, a lot is better, because you can overdo vitamins, but if you're just doing a once-a-day multivitamin and they make fun chewable forms now, that gives you a safety net with your children. And even if they're not eating really well, that provides some basic nutrition. But keep offering those foods, because their tastes will change and they'll start to eat things that they didn't eat before.
And be careful with those vitamins to keep them secured, because just like any pills or candy or whatever, children can overdo it.
Absolutely, because they taste so good.
Yeah, and they're fun.
Yeah.
Any other suggestions that you have, Dan?
Yeah, I think the point about just that toddler mentality, it's an experimentation when they learn the word no. It's very developmentally appropriate, and sometimes they really know how to use it well, and other times they're just saying it. My kids have answered no, and then I say, this is something you love, are you sure? And they'll change their mind and say, oh wait, I do want that actually.
Are you sure you don't want ice cream?
Yeah, they're in a series of saying no, and then they eventually will stop that. So I completely agree, continuing to offer, because if you keep doing that and keep making that a healthy choice that's just a standard within the family, most of the time kids will eventually at least open their taste buds to trying things.
And I always point out to parents, you've got to model that. You can't expect your child to eat green beans if you won't eat anything green. So you've got to model that behavior of eating a variety of foods and eating that food. So here's someone who wants to know how they get their 2-year-old to sleep better. He wakes up and gets in bed with us all the time.
Yeah, that is a tough, challenging road to go down. There's a 1,000,001 strategies online that you can read about. I think in the end, a lot of it comes down to if you have a pattern that that you break, even if it's, for oftentimes I see kids will regress or maybe have a hard time if they're sick. And then they come in and they're in, mom or dad's bed or mom and dad's bed, or they're sleeping on the couch, whatever it may be. If they do that once, it's going to take you 10, 20, 30 times to break that now one time that you established a new habit, because it's a lot more desirable for them. So I always talk about really good consistency in how parents respond to that. So if your goal is to get them to be in their bed, really having a good routine, being firm with that boundary, but not firm with the child. Still being really developmentally appropriate the way you talk to them, showing them love, that you're not alone. Mommy and daddy are here. I promise it's going to be okay. But if they do come and like our kids, they'll struggle with this still. They'll come running into our bedroom and it's okay. I'm going to pick you up. I'll take you back to bed. I'll tuck you in. It's going to be okay. But the minute they get into our bed, it would be, man, now we got the next month. We have to battle through this. So just good consistency.
I agree.
Anything?
And prevention is the biggest thing with that,
Yeah.
because once you start, it's a very hard habit to break.
I usually tell parents, if you want to sleep with your 3-year-old, you're the one with the black eye and bloody nose, but don't sleep with your baby. Don't sleep with your baby.
Yeah,
So,
Absolutely.
yeah. What should I be telling my child's teacher if we think he has some developmental delay? Craig.
Well, open communication with the teachers in the school system is really important, because you want to develop that team approach that, the parents are working with the school. You're not enemies. You're not trying to butt heads. You're trying to work for the benefit of that child. And so as a parent, you see different things than the school does, and you have to realize that what's happening at school is not necessarily what's happening at home, and vice versa. So you can't discount what the teachers are saying just because you don't see those same behaviors at home. But if you're concerned about your child's development, first of all, talk to their pediatrician, because they can do some developmental evaluation and/or refer you for some further testing if they feel there's something else going on. And then the school not only is required by law, but they're also morally responsible, and most teachers are wanting to do the best that they can for that child, and so they're going to work with you and try to meet their needs, have reasonable accommodations.
How many extracurricular activities are too many?
That gets to be really difficult really young. I find like activities are so common at 5, 6, 7 years old now. We talk about this a lot in the clinic, and I think it's really dependent on the family. So taking the approach of asking the kids what they have an interest in, but also I think it's reasonable to start presenting to kind of middle toddlers, 5, 6, 7, 8 years old. Okay, if we do this, it might mean we can't make every event for this activity, and just weighing some of that pro and con with them, because oftentimes it's, hey, I want to do 5 things, and we can make it to 100% of 5 things. And if it starts stretching you so thin on the parent side, it's really hard for the kid to see that if you can still get them there all the time. But I think involving them as they get a bit older and really helping them pick, all right, maybe you set one as a family that says we can make 2 activities 100%, so that's what we'll do. And if we still have extra time, maybe we could do 3 next year, or kind of bounce it back and forth like that. But I think involving the kid is important with that too.
And it's a whole lot easier to make 5 activities if you have fewer children,
Yep.
or an older child that can help with transportation and is still interested. I mean, it's got to work for the family too.
Yep.
So, yeah, absolutely. Here's a viewer who's thinking they've been looking at swim classes for children under 1. Are these safe, or should they wait until they get older? Craig, what do you think about swim classes?
The data shows that you should do some baby swim classes, but you cannot depend on that keeping your child safe. You can't say, oh, they're going to be safe near a pool now because they took their baby swim lessons. You still have to make sure that the pool is surrounded by a fence that they can't get into, and that you're going to be observing that patient or that child. But it's really important to get children comfortable with the water, and they're naturally very comfortable with the water as infants and young toddlers. And so this is a good time to prevent the fear of the water, but on this other hand, you can't just say, okay, they took their baby swim lessons, and so I don't really have to watch them near the pool or the beach because, you know, they're going to be okay.
Yeah. The drowning is a major source of...
Unfortunately, yes.
Yeah,
That's
it's a big deal.
one of the major reasons we lose
Yeah.
children is because of drowning.
And losing children is something we're all trying very hard
That's
to
so true.
avoid.
Yep.
Which is a great introduction to our next little clip here. No parent enjoys watching their baby get a shot. Prairie Doc reporter Sam Schauer spoke with a doctor about the vitamin K shot and why it is so important for newborns.
Dr. Laura Hofert practices at Madison Regional Hospital, and she consults with parents of newborns about the importance of vitamin K injections.
So vitamin K is a really important vitamin that basically helps us create our clotting factors through our liver that helps our blood clot. It's also very important for bone health. And the reason why we supplement it in newborns is because all newborns are deficient in that very important vitamin.
The vitamin K injection has been used since the early 1960s, and Dr. Hofert says a single injection must be administered within 6 hours of the newborn's life. If a newborn doesn't get the vitamin K injection, they are at risk for vitamin K deficiency.
Because all babies are deficient in vitamin K, they only have about 20% of those clotting factors that an adult would have. So by giving the vitamin K, we replace those factors right away in the liver, and also it's a slow release over the next 2 to 3 months to prevent that catastrophic bleeding.
And newborns who don't have enough vitamin K have a startling higher risk factor than newborns who do.
Babies who don't get vitamin K are 81 times more likely to develop severe bleeding complications than infants who get the injection.
Sadly, Dr. Hofert says about 50% of those bleeding complications happen in the newborn's brain.
So typically those babies are going to have poor neurologic outcomes, developmental delays, basically lifelong effects from having that bleeding complication. And actually 1 in 5 babies will die if they develop vitamin K deficient bleeding.
Dr. Hofert says while vitamin K deficient bleeding is very rare, it's because of the injections. If parents opt out, cases could rise.
The estimates are that if we stopped giving vitamin K injections, then potentially 12,000 to 80,000 infants per year could be affected by vitamin K deficient bleeding, which is about 200 infants per day. So while it does seem rare, that's because we've been so good about giving the injection.
Dr. Hofert ends by saying there are other chemicals in the vitamin K shot, but she assures they are extremely safe for newborns. She also clarifies that the injection is not a vaccine.
It is not a vaccine. So all it is a vitamin replacement. And the way we give that is through a single injection.
That is such important information. That vitamin K shot is just so critical. Why take the chance? Why take the chance?
Yeah.
So, here is a caller who is also thinking about newborns. When do I need to call the doctor for a fever in a newborn? Craig.
Well, certainly a fever in children less than 1 month of age is always a high priority because there's a high risk of infection, and infection in a newborn or a child less than a month of age can progress to be a very serious infection in a short period of time. So any true fever in a child less than 1 month of age, they need to be contacting their doctor.
Just be seen. Bring the child
seen,
in.
yeah.
Don't call. Don't wait
No.
for a call back.
No,
And
they need to be seen.
what is a fever in a
Yeah.
child under a month of age?
So it's 100.4 Fahrenheit or above. So 100.3, technically not a fever. Watch it really close, but 100.4, then it's all systems go, and you got to bring them in to be seen.
Yeah.
And should I be checking my baby's temperature all the time?
I don't ever encourage families to just randomly spot check, but if you ever have questions or concerns, I think you're always warranted to check, because if you're reassured, great, but if you catch something, the earlier you catch it, the better it's going to be. So I tell families that if you ever have a concern, if you feel like they're not feeding well, they do feel warm or they are sick, that's when I would check their temperature.
Absolutely. It's nothing to mess around with.
No.
Those little immune systems haven't had practice with anything, and they get
Yep.
sick too fast. So, and speaking of illnesses in children, my child gets ear infections at least twice a year. When should we start thinking about tubes? Craig?
Well, we don't have firm guidelines for tubes like we would for tonsils and strep infections, but you have to look at what age the child is and what time of the year it is, because the eustachian tube, the tube that goes from your middle ear to back of your throat, is straight across as a newborn, and by 3 it's slanting like the adult configuration. So the closer we get them to 3, probably the better off they're going to be. We expect normal, healthy children to get 6 to 10 colds a year, most of those in the fall and winter, and that's usually a precursor of ear infection. So if they're getting a lot of ear infection in the winter time, that's considered to be more normal. If they're continuing to get those frequent ear infections throughout the summer, then I'm more concerned that they may need tubes. So if you cannot get the infections cleared up with several different antibiotics, or you have persistent fluid, or certainly in older children, if it's beginning to affect their speech and their hearing, then you can refer them to the ENT doctor for consideration of tubes, because tubes definitely play a role, but they're not the magic answer for every child with an ear infection.
What is a tube? I mean, people talk
Yeah.
about that, but what is it?
Yeah, so it's really simplistically, for the most part, there's one main type of tube that I see used, but there's a few different types. Essentially, all it is you're taking a membrane that kind of separates your outer ear from your middle ear, and you are just putting a little hole through that and putting a little tube that I always describe it looking like a little Mario pipe, and it just helps to drain, and it helps with the pressure equalization. So then if that kid does get an infection, it's able to drain and come out of the ear canal, as opposed to sitting behind the eardrum getting full and causing that pressure that's there. So then it can most of the time help us not have to use antibiotics given by mouth as often, and we can use drops to just put the medicine directly in the right spot.
And sometimes you don't even need it. It just needs
Exactly.
to drain.
There you go.
So yeah, it's a rite of passage, and it's funny how you and I are of the same vintage, and people would go to the chiropractor and we would have them on suppressive antibiotics, and we would just do everything to avoid those tubes. And now my second-time parents are, now when can we get those tubes?
Oh yeah.
Because they can really, not always, but can usually make such a big difference and for the child. So. Oh, we were talking about this earlier. This is such a big issue. What can I do to help my child with bullying that's happening on social media? Dan?
Yeah, it's a huge, huge problem these days. That's obviously stating the obvious. But I think encouraging kids to work on who they are as people and be confident in who they are, and knowing that diversity and being unique is something that should be celebrated. And it's oftentimes not, especially at those transformational age levels, it seems like the middle school years, the high school years, when everybody's bodies and minds are changing so rapidly. It's really tough to keep everything really into a socially acceptable form of interaction. So I think encouraging those kids to know that this world should be a safe place, and that you shouldn't be you shouldn't be accepting being bullied online, or letting that be something that happens to you. And I've taken the approach too that, hey, if that's something that's happening online so much, then just back off of being online, because if you aren't present there, it might at least kind of stop that pathway from happening, because it seems to be happening so much more prevalently online these days.
Anything to add there, Craig?
No, it's just, obviously in today's society, people are going to be on media, and it's really hard to completely separate our children, but you still have to set those guidelines, and especially the younger children, where you have the ability to monitor what they're doing online. Because as they get older, you unfortunately lose some control and can have more issues. But if you develop that foundation for them early on, then it does get better as they get older. Hopefully they can make better decisions.
Yeah, it's a very dangerous world out there online, and
Yes.
it's hard for adults. It's doubly hard for children. Here is a caller who wants to know, how can they keep their child from getting hand, foot, and mouth disease at daycare? First off, what is hand, foot, and mouth?
Hand, foot, and mouth is a condition that is caused by a virus. As the name implies, the classic lesions are on the palms, the soles, and inside the mouth. And so the lesions inside the mouth are what's really painful for that child. Oftentimes the ones on their hands and feet don't bother them so badly, but we also see this sometimes on the trunk. It'll be on their chest and abdomen as well. Since it's a virus, it is very contagious, especially in those children who are mouthing toys and then spreading it around daycare. So that's why when it does get into daycare centers, it spreads quite rapidly. And since it's a virus, there's no magic medicine for it, and antibiotic is not going to help it. You just have to treat the symptoms and let it run its course. But yeah.
So, can I keep my kid from getting it?
I think it's almost impossible to do that if they've been in contact with it, quite honestly, because the difficult part with most viruses, but especially hand, foot, and mouth, is you could technically be contagious without having a lot of those lesions present. So you might not notice it yet, and then you're capable of spreading that to the other kiddo in daycare or whoever, maybe even mom or dad. Adults can catch it too. And it's very, very difficult to be able to catch one case and keep that kid, isolated so as not to spread it to others. Like you said, kids at that age, they share everything, and that's great until they start sharing germs, but it's inevitable.
But they're going to share germs.
They will. Yep.
And I think that's the thing. It's pretty much, it's like RSV. It's inevitable that you're going to get hand, foot, and mouth.
Yep.
At some point, you may have symptoms, you may have less symptoms. Everybody's going to get it, so we just got to nurse it through. So, all right. Here is a question: how important is the placenta to the health of a baby? And I'm going to throw that to the person who's married to a gynecologist.
Oh my gosh, I hope I can give an answer that lives up to her then, because now I'm set up. But it's really vitally important. The placenta is really what feeds the baby essentially during pregnancy. It helps to provide a lot of the blood flow and the nutrients and a lot of those abilities to grow for babies. Exactly, the oxygen, it essentially works as the lungs and the providing of all of the ingested nutrients for babies. So it's a very vitally important piece of the pregnancy for babies. And if the placenta is unhealthy, then oftentimes we end up finding babies who have growth deficiencies and who just don't get quite enough to grow to be large enough. And we know that some of those babies, if they're born very small, they can have more likely rates of needing the NICU to be in the ICU care, or more likely to have some breathing disorders when they're born, or difficulty feeding with that strength. So yeah, it's very important.
It's life support for the baby. Without a healthy placenta, you can't have a healthy pregnancy and a healthy baby. So. We have a question from a caller. What age should you introduce solid food to a baby? Craig.
Okay.
This has changed a little in the course of our time practicing.
It has. A child really does not need solid food until they're 6 months of age. And definitely there's risks to giving solids before 4 months of age. 4 to 6 months of age is kind of a gray zone. I usually tell people, go ahead, if you're interested in trying some cereal, go ahead and do that. However, if the child spits the cereal back out at you, then don't get stressed about it. And I usually encourage them to do cereal for about a month or so. and then we move on to yellow or orange veggies, and then the green veggies, and then finally the fruits. And when you're starting those baby foods, you feed the same food for 3 or 4 days before you start a new one. That way, if they react to it, you'll know what's causing it. And so, as we talked about before, I think it's important to expose babies to a variety of foods, because they're going to start to develop some of their tastes at that stage. And if they spit it out at you, hold off and try again some other time, and they might decide they like peas after the 12th time.
Anything to add there?
Yeah, the only ones I would add extra pieces about are allergies are such a big question these days, and I would say even in 10 to 15 years maybe, we've really changed our answer on, all right, don't even talk about peanut butter until they're a year old, don't bring it in the house. We used to say that, and now it's the opposite end, I would say, where we've found that no, actually the earlier, to an appropriate extent, 4, 5, 6 months old, if you can expose that child to something that's more allergically, more related to allergies, let's say like peanut butter, if they tolerate it well and you can keep that consistently in their diet, you actually might be able to decrease some of their risk for developing an allergy to that substance later in life. So I really like to talk about peanut butter, and as kids get a bit older, eggs and those sort of things that I think most people would associate with typical allergies, but that's the extra piece I like to add in too.
And if mom is breastfeeding, then she can eat those things, and we can get a little bit of exposure that way too, even before that 4 to 6 month age group.
Yes.
So, yes. Raising a child presents challenges in the best of circumstances. Throw in concerns of developmental problems, and some parents don't know where to start. Luckily, South Dakota has a program to provide services to those children who need some extra help.
Birth to 3 is a state program for children ages 3 and under with developmental concerns or problems. Stephanie Krusmark is the service coordinator for both Brookings and Moody counties, and she is the first person of contact to set up a screening for the child.
So we typically go into homes for the kids, just because that's where kids tend to perform better. And I always prepare parents by saying, what we do is going to look like play, because that's how kids learn.
If the screening says the child is eligible for the program, an early childhood educator like Ashley Hazelhorst will assist not just the child, but the family as a whole.
And so when I come in the home and ask the family what do they want to work on, then I encourage the parent to work with the child. And I just sit in the background kind of and help be a support as needed. And I give suggestions, I offer a lot of modeling.
Hazelhorst can work on any goals the parents have, like their child completing a puzzle or learning to get dressed. After the lesson, Hazelhorst will reflect with the parents on how they can use the skills learned in the future.
Because we try to set them up for when I leave the house, I want the family to know you're the child's #1 teacher, and you are doing great things, and you can continue to work with your child, and I'm just here to help give them ideas. And then I know that they're gonna hopefully, work on it after I leave. So.
When are you seeing this during the day, and write it into that time, that play time or that meal time or that bedtime or bath time, so that when they're doing those routines every day, they think, oh, okay, Ashley said I should try this, or here's something that maybe worked last time, and just trying to give them things, because we know it's not about the 30 minutes one time a week that we're in there that is going to help the kids meet the goals. It's about the things we're leaving with the families to do.
The child can graduate from the program or start other goals until they are 3 years old. Krusmark says if the child qualifies for the program, it will cost nothing for the family.
So I always say no matter what, it's a no-cost program. Sometimes we do look at other resources to use for it.
Krusmark ends by saying Birth to 3 offers many services like physical and occupational therapy, language therapy, and others. She also says while it is important for the child to get screened as soon as possible, it's never too late to call.
It's all the families we get, it's like they've tried these things, they've done these things, and I think they're amazed when people come in and just give them maybe a different way to look at it, like, oh, I've tried that, but I've never done that with it.
I love the Birth to 3 program. It is just such an incredible resource, and I just absolutely love them and appreciate everything they do.
Yeah, I agree.
Yes. All right, we've got a fair number of more questions. This is super exciting. So here is someone who wants to know, we were talking about breastfeeding. How do I properly store breast milk?
Yeah, so it really depends on what you define as store. So the length of time, I guess, you're storing it is really what would answer that question. If you're going to try to utilize it right away, then the best answer is to utilize it right away. So that might mean offering it in a bottle or something for baby. There are some guidelines on different websites. If you look up on some of the common pump brand websites, they can give you some rough guidelines. Typically within the fridge, you might be able to get a day or two, a couple days out of breast milk. Really, the longer type of storage you're going to need to do in a fully separate freezer. So the refrigerators that are the tiny ones that have the little freezer compartment at top don't really count as well. But if it's a separate freezer, then you can typically get 2 to 3 months maybe of storage time from it. And from what I've read, the deep freezes you can get a little bit more, like 6 months, maybe even beyond that if you properly store it. Doing that typically needs it to be in a bag, and usually most of them have kind of a double seal on them just to help prevent any spilling or leakage. And then the biggest thing too is reading online how to properly thaw that milk as well, because that's one of the larger things. So the easiest way is if you do that kind of slowly and you let it thaw in the refrigerator as you pull it out and then utilize it the next day.
You can't just throw it in the microwave?
Can't just heat it up real quick like that.
Man.
Yep, I know.
And here's kind of a related question. Well, I think it's related. It may not be obvious, but my baby's poop is weird colors sometimes. When should I be worried, Craig?
In general, the color of the poop is really not an issue. Depending on what you're eating, your poop color is going to be changing, and so normal has a wide range. I mean, if they're truly white or very pale clay-looking stools, that could be indication of a problem with the liver, and that might be something worthwhile bringing up. But any shade of black or green or brown is
yellow,
is going to be normal probably.
Yes. Is there a difference between breastfed baby poop and bottle-fed baby poop?
I do find that there is. Traditional breastfeeding stools, you'll hear people talk about yellow, seedy, loose stools. And the number of stools really varies. I would say I've got some breastfed babies that go 5, 6, 8, 10 times a day for months and months and months, and others that will go 2-3 days without passing a stool. And it comes out and it's very soft and the appropriate color and checking all the normal boxes, but that timing varies a lot more. I traditionally have found that some of the kids who are taking larger volumes of Formula 2, it might be a little slower moving, not to the point where they're typically getting constipated, where it's harder balls of stool, but you can see it stretch to that extreme as well.
How do you define constipation in a kid?
Well, as he was pointing out, I'm more worried about the consistency of the stool rather than if they look like they're turning red and grunting. If they're red and grunting and they have normal soft stools, that's not constipation. When they have the little hard rabbit pellets, that's probably constipation, and breastfed babies are less likely to be constipated than formula fed. But
we have a question here, a 4th grader who gets constipated all the time. What can they do?
So constipation can be really difficult because it's looked at, I think, traditionally as just a momentary thing, and if I can treat it, it will be better. But oftentimes if you have struggled with constipation for a long period of time, your bowel actually gets stretched, and when it gets stretched, it can't squeeze properly anymore. So it's not just treating it in the moment and saying, hey, we had a tough weekend where we gave a lot of Miralax or whatever substance it might have been, and we passed a lot of stool, but it's continuing that to really make sure that you keep the stools moving easily and coming every day, and that they're a smooth, softer consistency for sometimes 6, 8, 10 weeks after you've initially treated the constipation. Then you can start to backtrack it. So I find that traditionally the kids who are struggling with, they always get constipated. It's really more of a long-term run of one constipation that just hasn't been fully treated.
Any tips, Craig?
Well, constipation is a chronic issue, and people who are backed up with stool didn't get backed up in a couple days, or probably even a couple of weeks. It's months long. And I do a lot of work with constipation because it is something I see every single day in clinic. And we just don't have enough fiber in the American diet, and I think that's why it's so prevalent. But the clean out is always the hard part. Once you get them cleaned out, maintaining them isn't as bad. You get more fiber into their diet, maybe some low-dose Miralax or stool softener, but the cleaning out phase, whether you're trying to do that with magnesium citrate or Miralax or some other approaches, it's never an easy process. And
it hurts.
And many times, they'll say, oh, they got really cleaned out, and then you do an x-ray and compare it with the last one, and they are just as backed up as they were before. So I do a lot of x-rays just because show and tell is really important to the parents, because then they can actually realize how much stool's in there.
Yeah. My child's school has said there is a rise in teenage suicide. What do I need to look for in my teen, since they're moody in general?
So this is such a big topic, but I talk about this when I see kids that are 10, 11 years old. I really start to bring it up at their well child visits. And the way I try to empower those kids is to say, I get the sense that when kids are struggling with feelings of depression or whatever might lead to some of those thoughts of suicide, it can be very isolating. And knowing that there's avenues that it's okay to talk about this if you are feeling that way, then we can get you help and help you to be in a safe place until we can help figure out maybe what the inciting factors were, what led to those feelings, and so that we can help you get to a more stable place. So I really try to take that approach with kids. I think trying to empower kids to know what their resources are as well, that there are hotlines that are available that you can pick up the phone and call, you can message system with, you can have text messages, emails, you can have voice chats, or anything with national hotlines that are available. And those are a quick internet search away for kids who most of the time at that age will have a phone in their hand at the ready. But I really just try and encourage them that even when you might feel alone, reach out to somebody who's a safe place, and typically that might be a parent or caregiver.
Mm-hmm. And I always try to really emphasize to the parents gun safety, especially because your child may know exactly how to be safe around guns, but in a bad moment, if it's too easy to access, it can be deadly.
Yep.
So, here's a caller who wants to know if it's safe for their baby to be in their car seat for a long ride. Craig.
Well, absolutely. If they are in the vehicle, they need to be strapped in the car seat. It's never safe to take your child anywhere, even around the block, without putting them in a car seat, because if there's any type of accident or even braking rapidly, the child is going to fly forward and it's going to be unsafe. So every car seat has some requirements for weight and height, and it's important to choose the right car seat for your child. And so I think that we need to continue to encourage car seat use, and in fact the guidelines show that you should be in a booster seat generally up until 8, 9 years of age. It's a height thing, and so for a lot of kids they're going to need to be in a booster seat for that longer, and of course they think booster seats are for babies and they're going to fight you over it, but it's still a safety issue.
Mm-hmm. Yeah, it's the only safe place for your child in a moving car is in a car seat.
Yep.
So we are almost out of time, so one quick thing. How do I tell if my baby is fussy or sick?
Yeah, so that's a difficult thing as well. I would say if you can try normal interventions that would typically soothe them, and you can get some moments where they're able to calm down, whether that's rocking, or if you choose to use a pacifier or swaddling, or sometimes even feeding or a warm bath, that gives you some reassurance that it's not something that's so persistent that it's from an illness. If you're trying your typical interventions and nothing is working, or it's been hour, 2 hours, I mean, you're stretching into longer periods of time. Certainly if you're having other symptoms with it, like vomiting or fevers.
Just
then
like
you need to be seen.
we talked about before.
Yep.
This has just gone so quickly. So it has been a wonderful conversation with you, gentlemen, and thank you so much for joining us.
Thanks for inviting us.
The winner of our prize tonight is Louise. Thank you, Louise, for asking a question during the first 20 minutes of the show. A gift will be sent to you. And we'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 21 seasons. Join us as we continue to provide health information based on science, built on trust. Follow us on Facebook, Instagram, and YouTube to access the entire Prairie Doc library today.
It's human nature to tell stories about the past, and doctors aren't immune to that impulse. The second-year medical students rotating through my clinic have had me reflecting on my own years as a fledgling physician and the changes I've seen in my decades of practice. I remember one late evening spent in the pediatric intensive care unit watching over a toddler who had meningitis. At one point, I turned and bumped into a bed rail, which came crashing down. Both my preceptor and I jumped, and I probably even shrieked. The child, however, didn't even blink. And that's when we knew her illness had left her profoundly deaf. The seasoned pediatrician I was with that month had started practice before the introduction of the Hib vaccine. As we talked about what we could do now for the child in our care, he told me stories from the old days, when the PICU at Sioux Valley Hospital would perpetually have 2 or 3 children being treated for meningitis. Less than 10 years later, our unimmunized patient was the first case they'd had in months. Early in my own practice, winter months would see at least a child or 2 here in the Brookings Hospital with rotavirus on any given day, and the occasional adult. They would be with us for a few days or even a week, getting IV fluids until the diarrhea slowed down. Our first vaccine had rare but serious side effects and was pulled from the market. But the rotavirus vaccine we've been using for nearly 20 years now has turned the illness into something that rarely lands a child in our hospital. To be sure, we still see rotavirus infections. It's just that far fewer patients are so sick that they require IVs. This last year, we got a new weapon against another common childhood scourge. RSV has been a terror for longer than I've been in practice. It results in the hospitalization of nearly 2% of children before they turn 1. We now have 2 ways to protect infants. The first is a traditional vaccine, but it's given to expectant mothers late in their pregnancy. Mom's immune system responds by developing antibodies which are transferred to the infant. Since babies' immature immune systems can't respond to the vaccine we have for RSV, we can't give it to them. However, we have an antibody against RSV that can be given directly to newborns. We've had something similar for most of my career, but it was expensive and had to be given monthly, so we only used it in the highest risk children. This new version is much less costly and requires only 1 shot. These strategies don't teach the baby's own immune system to fight the infection. Instead, they provide temporary soldiers to wage the battle. That protection will fade, and the baby's immune system will still have to learn to fight RSV by catching it, but we will have delayed that day until the child is older and less likely to get terribly sick. I am optimistic that RSV too will become something we still see, but that doesn't cause the suffering it once did. And I wonder, what will my young colleagues someday tell their future students about medicine in the old days? thank you to our guests, Dr. Boadwine and Dr. Crismon, for volunteering their time to help us learn more about pediatric care. The Healing Words Foundation depends on the volunteer work of many professionals. And tonight we want to extend condolences to the family and friends of 3 valued contributors who have passed away this season. Dr. Matthew Owens was an amazing doctor and advocate for rural health care in our state and beyond. He was a longtime supporter and a frequent contributor. Bev Warney was a powerful voice for diversity throughout her 50-plus years of service as a nurse, educator, and mentor, especially to Native American nursing students across the globe. She was a valued member of our board of directors. Dr. Susan Anderson was a practicing clinician who also held several leadership positions with the USD Sanford School of Medicine. She appeared with us several times, especially to discuss the Frontier and Rural Medicine Farm program. Their passion and dedication will inspire us as we continue on their efforts to transform healthcare for the better. To their family and loved ones, our heartfelt condolences. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us live most Wednesday mornings at 9:30 on KBRK Brookings. Be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science and built on trust. Till next time, stay healthy out there, people.
Your skin is a great indicator of your overall health. It is your largest organ and can protect you from heat, cold, germs, and dangerous substances. Sometimes changes can be an indication of a medical problem. Changes to your skin. Dermatology. Next time on Call with the Prairie Doc.
My name is Jennifer May. I'm a rheumatologist in Rapid City, South Dakota. I got involved maybe around 2005. That's when I first started practicing in Rapid City, and my former partner introduced me to Rick and actually got me on the On Call show. I think we did a story on gout, and that was my first introduction to Rick and the Prairie Doc sort of concept. And it's a great resource for information. We have a lot of people that live in remote places. They maybe don't have a lot of good access, and we know that there's a lot of misinformation in terms of health information that you can get online, and having a reliable source for people to go to with people they recognize that they might know on the programming, I think is really important. Well, I think having anything that isn't tied to an agenda is really important, and so having access to information that you can refer your patient to, that you know they're not going to get fees or get their data sold, is really important. I think if people want high quality programming from local people, local experts that supports your community, supporting Prairie Doc is the way to go. For more information or to donate, please go to www.prairiedoc.org or mail your donation to Post Office Box 752, Brookings, South Dakota 57006. Thank you for your support.
Major funding for On Call with the Prairie Doc has been provided by
Out here, the day starts early and ends late. You don't love this land because it's easy. You love it because it's home. At Avera, we're built for rural healthcare. We're bringing quality, innovation, and advanced technology to your vibrant communities. Care when and where you need it. That's how Avera moves health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health, Dakota Dermatology, Vance Thompson Vision, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Orthopedic Institute, Aberdeen Asthma and Allergy, South Dakota American College of Physicians, Cool Beans Coffee, Lake Poncet Sailing Academy, and Swiftel Communications.